So much, Amina, for giving us some basic lung function test interpretation. And now over to you.
Hi, Sidra. Thanks for inviting me. My name's Amina Mohammed. I'm the co-head of respiratory physiology at Sandwell West Birmingham Hospitals. I've been asked by Sidra to give a basic lung function interpretation presentation. So bear with me. Let me just. So first of all, I'd like to say that we follow the Association of Respiratory Technology and Physiology Organization, called the ARCP. Our organization promotes excellent practice, and we develop service development standards for departments throughout the UK. So we do follow recognised standards, and I'm not going to go too much detail about this, just to know that we do have the skills and knowledge for interpretation. Okay. I'm just going to start off with basic things. So obviously, if you want to learn more about lung function interpretation, there is the ARTP website where you can look at the standards of lung function interpretation, or you can go into ATS ERS, and they have the technical standards as well, and for interpretation. So there's vast amounts of knowledge out there. So but this is what I'm going to apply is just basic lung function interpretation and what you would see in a report in any organization. Okay, so I'm going to start off with this slide. This is what you would see in our department, and in various departments you'll have exactly the same data that you will see. So you will always have obviously the patient's name, date of birth, age, sex at birth, which is very important, and you'll have values which are the actual values, the predicted values, the lower end of normal value, you have percent predicted, and the standard deviation, which is also a Z-score. Okay, so you also will have a lung function spirometry, lung volumes, diffusion, usually saturation, and you will have a graph of a spirometry loop with a picture of where the normal range would be, and also you have a flow time graph as well, so you can see how long the patient has been expiring. So spirometry is a simple breathing test, and it helps to diagnose and monitor certain lung conditions. Before you do a spirometry test, there are contraindications and considerations you need to look at prior to testing, and this should be discussed and noted on the actual report, so that you can bear that in mind when you're interpreting the results. So spirometry test is repeated until we have 3 technical acceptable results, and they have to meet reproducible standards. For us, it's the FVC within 150 or 150 ml if the VC is less than 2 litres, and both 5% of each other. The peak flows within 10%, but you do have to have a maximum 8 attempts to be able to obtain the above criteria. So you have to keep continuing until you get 3 technical acceptable results. Okay, so the spirometry parameters are FEV1, which is the forced expiratory volume per second, the forced vital capacity, which is the FVC, the peak expiratory flow, and the FEV1 FVC ratio, which is a percentage. Okay, there is also the forced inspiratory vital capacity, and there is the FEV 25 to 75%, which is the mean expiration between 25 and 75% of the FVC duration during a maximal forced expiratory maneuver. So these are the things you tend to see on a spirometry loop. This is kind of what you would see in textbooks. So you can see the spirometry graphical interpretation, and there's a normal graph. What would you see in a restriction and an obstruction? And also in the time curve, you can actually see how quick and how slow your breathing is with these maneuvers. Just what I want to look at the moment is the grading of obstruction. This has changed in recent years. For many years, we were using the ATS ERS 2004 for grading obstruction, and also for the NICE 2010. This is still used by Gold even up to 2023, and where they still use the fixed 70% to reduction in 70% post bronchodilator to grade obstruction. So you have to see a reduction of 70%, and then they will use a FEV1% predicted to grade that severity. We have changed this now, and I'll discuss this further. So we now use the lower limits of normal, or Z scores, and this is the reason behind that is because we know from published data that using fixed percentages leads to overestimation of COPD in the elderly population, as well as underestimating the younger adults. And there's been a lot of research and a lot of data to develop reference ranges, reference equations, and they are now within the guidelines. They've actually now been advised and recommended throughout the worldwide. These are the GLI reference equations. This is the Global Lung Function Initiative, and these are sponsored by the ERS ATS, and there's published data there, so you can go and have a look at those. So basically what they're saying is that the normality should no longer be defined as fixed percentages, but by the lower limits of normal. So what they're saying is that if you are within the bottom 5% percentile, then there's possibility that your results are abnormal. So the recommendations really strongly discourage you using this FEV1 FVC ratio cutoff for obstruction. So if we look at an obstructive spirometry, we can see that the FEV1 FVC percentage ratio will be reduced for the lower limits of normal. The FEV1 is usually normal or reduced. FVC is normal or reduced, and the peak flow is normal or reduced. And the kind of obstructive disease that you see in COPD, asthma, bronchiectasis, emphysema, cystic fibrosis, and now emerging sarcoidosis. It used to be more of a restrictive deficit, but in more recent times you are seeing obstructive element. So grading an obstruction, as I said before, we're using the lower limits of normal, and this is Z scores less than 1.645 to be classified as an obstruction. So you can see here that we use the ARTP grading severity, mild, moderately severe, severe, and very severe. The differences with the ATS and ERS is that they only have 3 grades, which are mild, which is 1.64 to 2.5, then it's from 2.5 to 4 is moderate, and then more than 4 is severe. They don't have 3 categories, but we tend to use the ARTP 2020. Okay, so with restrictive spirometry, you see a reduction in lung volume and expansion. So you'll have this restrictive pattern. You normally see a reduced FVC. You can see a reduced FEV1, and obviously the ratio is increased, and sometimes you get normal or reduced peak flow. And this kind of pattern you see with conditions such as interstitial lung disease, sarcoidosis, neuromuscular, or very marked obesity, and some adverse drug reactions such as methotrexate. Again, we grade the severity using the lower limits of normal, and you can see there it's similar to the grading of obstruction. So these are just a few kind of flow volume loops that you can see. Start off the first one, which is the normal spirometry. With B there, you can see that with the obstruction, you'll see the starting of the curvature of the loop. So within like moderate, mild to moderate, you'll see that curving, and that is quite common picture you see with that obstruction. With a severe obstruction, you see that airway collapse and that classical steeple picture where the expiration is taking a long time to come out. So you see that in a severe obstruction. In D, it shows you a variable extrathoracic obstruction. Usually doesn't with the extrathoracic, the expiration is okay, but you do see this reduction of flow in inspiration. With E, it's a fixed large central airway obstruction, so you see the flattening, you see a plateau flattening at the upper airways, so that's really common in upper airway obstruction. In F, you do see these changes in flow depending on where the bronchial obstruction is. G is a restriction, and with the last one, you can see that it looks similar to C. So you can see like a severe obstruction, but they can't empty fully. So there may be, this is a restrictive element, so that means they may be not being able to fully expand, or there may be a restrictive disorder that you need to look at. But without having full lung volumes on that, you wouldn't be able to make that distinction, but you would be able to say there's a mixed disorder there. Okay, so with spirometry, we do reversibility testing. So the patient is given 400 micrograms of salbutamol via MDI and spacer. We try to standardize that here. There are many ways of giving bronchodilator with regards to whatever the patient is actually being given, but we just have a standardized bronchodilator here to make it more effective in the clinic. There is a 15 or 20 minute wait before repeating that spirometry. There are classifications of reversibility, and there is a lot of debate about whether you call it reversibility. There is more bronchodilator response. At the moment, we use a NICE Gold ATS ERS guidelines, which is an increase in FEV1 of more than 200 ml and an increase 12% change. Now, there's other examples like the ARTP and the BTS, and there is actually more changes now with bronchodilator reversibility. So these are the kind of waiting times that you have to make sure the patient has withheld other medication before you can actually do reversibility testing. It is difficult to know whether the patient has withheld those, but you just have to assume that they have. You do have to document if they have used any of the longer acting agents, because that will affect or dampen the effect of the bronchodilator response. So you need to make that observation and let the clinician who's reporting it so that they can add that to the report. So as I said, there's some new changes in the way we measure bronchodilator. So we have the ERS ATS 2021, the new guidelines, where it looks at the difference in post bronchodilator, take away the pre-bronchodilator, and then they divide that by the predicted value, and they're saying the positive change is 10% of the predicted value of FEV1 or FVC. So this isn't the change between pre and post bronchodilator, it's a percentage change relative to the individual predicted value. So with all these, it's just you've got to be careful not to have fixed cutoffs, because they are prone to the same limitations of the lower limits and normal as well. So you just have to use these as guidance and obviously look at the whole picture to see whether there's any valuable bronchodilator response seen. Okay, so there's other ways of expressing bronchodilator change in the RTP lung function statement. It looks at Quandra 2017, where they say an 8% increase in FEV, 1% predicted favours a diagnosis of asthma on active treatment. There's also looking at the Z score. So if there's a difference of 0.78 in the FEV1, that has been proposed as a clinically meaningful change. And also with FVC, if their Z scores are more than 0.64 in FVC and it's more pronounced in severe obstruction, suggesting there's a clinical important relief of hyperinflation. So it means that they're able to, what happens with the severe obstructions is that they just can't breathe any longer. And obviously if they have relief of that hyperinflation with the bronchodilators, they're able to breathe out a bit longer. And so obviously you do have to make sure you clearly tell on the report which guidelines you are actually using. As I said, for now we are still using the ATS ERS guidelines for bronchodilator, but I just thought I'll express the different changes in bronchodilator response that has been reported, and hopefully once we make the changes it will be on our report. So I just want to have a look at some lung function so that we can start looking at how we report a test. So as you can see from here, this is have an action on this report. You can only cut off, but it's a female and the age is 42. So if you have a look, when you first start to look at, you can actually look at the spirometry and you can see that it looks like there's an obstructive picture there. And then you can see from the FEV1 FVC that the ratio is lower than the lower limits of normal. It's 53.8%, and the lower limits of normal is 70. So that shows you that that is definitely below, so it is an obstruction. You then go to the FEV1, which is 1.48, and you can see that the Z score is 4.22, so it's well below. So it's very, very low. And if you look at the grading, it is more than 4, so it's a very severe obstruction. You look at the FVC, this is still reduced, but it's moderately reduced, but it's obviously the person is obstructed, so they're probably not able to fully empty their lungs. Okay, so then you'll see though that the peak flow is reduced, but that shape and also the actual it's showing us that this is a severe obstructive spirometry. Patient was given salbutamol, 400 micrograms via MDI spacer, waited 20 minutes, and a repeat spirometry shows significant bronchodilator response. And if you see, that is well above any of the criteria, so it's quite clear, 64% change and 46% change. So we still look at percentage change as well as how many mils. So that's nearly from 1.48 to 2.42. That's nearly 1,000 mil change in FEV1, which is really, really significant. So when you look at the post-bronchodilator spirometry, you can see that if you were to go back into grading that spirometry, it's still below the lower limits of normal, so it's still an obstruction. However, 2.42 is now 1.86 on the Z score, and that it goes into the mild category. So now the post-bronchodilator spirometry is a mild obstructive spirometry. This patient also had a FeNO score of 64. This FeNO was done prior to the spirometry. We always start with the FeNO, and this shows high levels of nitric oxide in the exhaled breath. So that is usually significant for levels of inflammation. Okay, so we've covered spirometry. So what we're going to do now is cover the other tests that we do in lung function tests. So this is a transfer factor. So this test measures the rate of gas transfer across the alveolar membrane. So during this test, the patient will inspire the gas, and the two main gases are carbon monoxide and methane. Okay, so what the patient has to do is, say, wear a nose clip. They're asked to breathe normally for a few breaths. They're then asked to take a big breath. They have to breathe in, but then fully all the way out to residual volume. So really fully all the way out. Then they're asked to take a big breath in, and the breath has to be within 2 to 4 seconds. Breathe it all the way in, and then they hold their breath for about 10 seconds, and they're asked to breathe all the way out. So this is so that we can measure the expired breath to see how well these gases diffuse in the lung. For reproducibility, you have to make sure that the patient actually breathes in. The IVC has to be more than 90% of the VC, the FVC that was recorded earlier. And that shows us that there was enough breath taken in to make that a valid test. And we only do a maximum of 5 attempts because there's research that shows more than 5 transfer factors will start to impact on the actual results. And the more you do, there'll be a reduction in the transfer factor. So when you interpret the TLC, the TLC is an estimate of how much gas per unit pressure difference from the alveolar to pulmonary capillary. It provides you an indication of how well the lung is ventilated, and also how the distribution of gas is normal. Than any abnormalities in the DLCO can indicate if there's a disease at that alveolar level. The KCO is really looking if there's a presence or absence of disease at an alveolar level. It distinguishes between extrapulmonary and intrapulmonary, like for restrictive defects. The diffusion also gives us a measurement of alveolar volume. This is important when we only do spirometry and diffusion, because providing that the spirometry is normal or mild, we can get a very good alveolar volume, which is a marker for TLC. So that is a very useful measurement in that. Whereas if it's a moderate to severe obstruction, you really can't take that alveolar volume, because obviously there is a problem there. With someone with an obstruction, they're not going to be getting, when they're breathing in, they're probably not going to be going into the ventilated areas. So that's why that's not accurate, and you always see that's a big reduction between alveolar volume and TLC with the moderate to severe obstructive patients. So when we interpret DLC with regards to severity, the Z scores at the moment are not very, they're showing the impairment, the severity is too high when you're looking at the lower limits of normal. At the moment, the GLI task force are looking into these equations. So currently, we're still using percent predicted. So we tend to, if it's above 60%, it's mild category. 40 to 60% is a moderate, and below 40% is severe. But we do tend to see that unfortunately the lower limits of normal still not very sensitive. If we look at some interpretation of TLC and KCO, you can see I've listed there a couple of diseases that where you'll see either both TLC and KCO decrease, which we see, as I said, in COPD, emphysema, sarcoidosis, pulmonary fibrosis. When they're both increased, it's usually seen in asthma or polycythemia, sometimes where there's a lot of blood, like in hemorrhage and things like that. You can see high TLC and KCO. To be honest, we've never tested any patients with hemorrhage. So it's just I've never seen that. Decreased DSCR and increased KCO, you see this with muscle weakness, any skeletal deformity. So basically what that means is that there's a extra thoracic cause of so their lungs are actually fine, but they can't expand their lung because of the chest wall diseases or muscle weaknesses, but the actual lung function is actually quite normal. So this is the actual the new ERS ATS standards for diffusion, and this is what I was talking about in that it's look with the lower limits of normal. You know, they've got these ways of looking at it, but it actually shows quite that it's not comparable, and it's making it a bit more severe than it is. So I'll move on. The third test that we do is lung volumes, and we do body plasmography. There is also nitrogen washout that we do when we're not able to get a plasmography. But I haven't actually covered it in these slides, unfortunately. But the body box plasmography is the gold standard for lung volume measurements. The way it's performed, it's in an airtight chamber, so that we can establish thermal equilibrium. The patient is sat in the box, and you wait a minute or two to get that equilibrium. They're asked to take some normal breathing, and then they're asked to pant against a blocked, like an occlusion at the mouth, so that we can measure the pressure at the mouth and the box. And then they're asked to breathe all the way in as far as they can and all the way out as far as they can, so that we can get a good SVC measurement, and also that way we can actually get a good TLC measurement that's derived from that. So again, with it reproducible, they have to be within 5% of each other, and we do a maximum of 8 to get at least 3 reproducible results. To a restrictive TLC is below the normal limits, and this confirms a restriction, as a spirometry can only indicate a restrictive deficit. So you can you can look at that. So as I said, with regards to spirometry, you can make that to suggest there's a restrictive impairment, but then you need to have a lung volumes measurement to confirm that restriction, and you will that to confirm that the TLC will have to be reduced. With obstruction, the TLC is always is either normal or increased, but you do see this higher FRC and RV, which suggests gas trapping and hyperinflation. You've got to look at the percent predicted, and they do say that more than 120% is actually normal. So sometimes you can see that it looks raised, but actually you have to look at the whole of the TLC and the VC, because it just could be that the patient has got normal measurements, like super normal. So with lung volumes, so if we look at the actual whole lung volumes, diffusion and spirometry here, you can see that with an obstructive picture, you'll see a normal or high VC. FEV1 is usually normal and reduced, and the peak flow is normal or reduced. The diffusion in an obstruction, the TLC and KCO are usually normal or reduced. In lung volumes, the TLC is increased, RVs are increased, and also the ratio is increased. So I will skip that. I've added some things that are a bit too much at the moment. So in a restrictive defect, the spirometry in the FBC is reduced, FEV1 is reduced, the FEV can be normal and can be reduced. The diffusion, TLC is normal and can be reduced. The KCO is normal, it can be increased or reduced depending on what's the cause of the restriction. In lung volumes, the TLC is reduced, the RV is reduced, but the ratio can be normal. So let's have a look at some actual lung function tests so that I think this is the best way to actually learn how to interpret the lung function. So if you look at the referral, the referral says it's an asthma patient with increased shortness of breath. If you look at this, it's unfortunately I haven't put what sex the patient is, but it is a male. The age is 17. The way, if you can look at the BMI, is quite a thin person with the BMI of 21, and they had full lung function tests and reversibility. So on the pulmonary function test, you can see that we've got the standard residuals. So you can see at the top that the category for mild, moderately severe, severe, and very severe at the top. And also you can see what agent we use for reversibility. So if we have a look at some of these figures, you will see that you've got the actual, predicted, the lower limits of normal, percent predicted, the Z scores, and also the post bronchodilator scores to the side there. So if you have a look, first of all, the way we interpret, you have a look at the FEV1 FBC percent ratio, and you can see the lower limits of normal for the patient is 75%. The patient was 51%. So we know that this is an obstructive picture. Then you look at the FEV1 and you look at the lower end limits. So you see that this person is definitely FEV1. Can you see there? It's should be 3.33, but patient actual results were 2.19. If you have a look at the Z score, which is 3.86, and look at the actual grading of that, it comes under the severe category. So the FBC is actually within the normal and lower limits of normal. So that's a normal FBC, reduced FEV1, reduced ratio. So that is an obstructive spirometry. That's really all you need to know, to be honest, with looking at spirometry. And that's what we tend to look at. If we're in doubt with the figures, you can have a look at the other things like IVC. So sometimes if someone has made a poorer effort on IVC, if the force inspiratory vital capacity is bigger than the FBC, then you know that the patient hasn't breathed out as fully, because you should be able to breathe in as much as you can breathe out. So that is a good test. So we have a look at the reversibility. So the patient was obviously tested, spirometry done 20 minutes after the bronchodilator, and you can see that the patient, there is no bronchodilator response. If you look at the lung volumes, you can see normal TLC, where you can see increased RV and an increase FRC and an increase RV TLC, which is showing us that there is gas trapping in the high RV and high FRC, showing hyperinflation. The TLC, you look at, it's normal, but the ratio is reduced. So with this patient, you would say that there's a severe obstruction with no bronchodilator response. We've got normal TLC and gas trapping and hyperinflation, normal diffusion and resting SpO2. So we tend to just write the report as we see it and not really make any comments at all because you need more clinical information to make a diagnosis. But we can definitely see that this patient has an obstructive impairment. We can have a look at this one here. This was another referral for asthma. If we look again, it's the same principles that we use for reporting. So with every patient, if there is a comment about the patient's techniques or errors or anything like that, it would be put on the report. But you can see here there's nothing on the report, so these were technically reproducible results. Again, we always start looking at the picture, and you can see that we can see a little bit of a curvature there. So in your head, you're thinking there's a possible obstruction here. So we have a look straight away at the FEV1 FVC percent, which is 65%, which is below the lower limits of normal, is 73. And we go then to grade it. We look at the FEV1, which is minus 3.12, which is in the severe category. The FVC is also reduced, but obviously again, with you have a look when you have the picture of the total lung capacity. If you look at the total lung capacity, which is 5.38, which is normal, so obviously that FVC, reduced FVC, is unlikely to be a true restriction. So it's just possibly that the patient just cannot breathe any longer. And so you can see that that is a severe obstruction. If you look at the lung volumes, the TLC is normal, but the RV is increased, which is suggestive of gas trapping, and the diffusion is normal. So, and then with reversibility, you can see that it is still obstructive, but the FEV1 now is 2.26, which is actually in the moderate category. We do see a 12% change in FEV1 and 10% change in FVC, and also there is more than I think it's 188, so it's quite considerable mils difference in FEV1, so that is a positive bronchodilator response. Similar again, you look at the loop, and you can see that is a picture of airway collapse followed by forced expiration, which obviously takes a long time, more than 10 seconds, and it shows an obstructive picture. But again, you look at the FEV1 FVC, and you can see a reduced lower limits of normal. You go to the Z score on FEV1, which is in keeping with 3.87 is a severe category, and the FVC is again reduced, but we know that FVCs can be reduced in severe obstructions due to hyperinflation and not being able to fully expire. And then you look at the TLC. The TLC shows you an increase total lung capacity, an increase in residual volume, and an increase in FRC, increase in RV and TLC, and this is all it shows you like increased lung volumes, gas trapping, hyperinflation, which is seen in severe obstructions, and it's in keeping with diseases such as emphysema. However, if you look at the TLC and KCO, you see that this is normal. So with that, when you look at if you looked at what we said about the severe obstructive obstruction, you would have saw a reduced TLC and reduced KCO, but this is normal. So it's possible that this patient may have a reversible element to keep it. So they may have an asthma element in there, but obviously reversibility wasn't done. But just the fact that they've got a normal diffusion may indicate that there may be an asthma element there. This is just to show you that the importance of monitoring. So this is a patient with sarcoidosis, but they have normal lung function, and over a period of time, you can see that for the last 7 years, they've been monitored yearly, and you can see that they're within normal variability, and for normal variability up until 2020, so that you can see they were from 2016 to 2019, they were pretty much the same. They did have a reduction in 2020, but then that's kind of stayed the same for the last 3 years as well. So that's depending on their what's changing. I haven't got to hand, but I just wanted to show you the importance of monitoring, because it's not just about the values, which we can see here are absolutely normal over time. Depending on the patient and treatment, you can see the effects or deterioration of their disease. So again, sometimes the reason I've showed this lung function test is that you do get referrals for patients with diseases, and they have increased shortness of breath. They want to query whether they've got asthma or early fibrosis, and the lung function itself comes back absolutely normal, and you can't see anything within that lung function. But that doesn't mean that the patient doesn't have all those issues, and they may be symptomatic. So this is an example where lung function alone isn't going to help you with the therapy and treatment of that patient. But at least you can see that their lung function is within normal range for that patient. Sometimes you'll find that you have really different flow rates from the spirometry. So even though their lung function is actually quite normal, without having a picture like a spirometry picture, you would not be able to see that actual flattening at the top. Something suggests there's something not right because the peak flow is quite low, but having a spirometry loop is quite good because you can actually see that plateau, which is in keeping with upper airways obstruction, and you can see, and that is usually quite common with like people with a goiter. Sometimes we have young adults, so we see patients from about 16, so their spirometry can look a bit different to the adult population, and this is just due to the high elastic recall. So you can see that they do quite they breathe within 1 second, so sometimes the FEV1 FVC is nearly the same, but again, this is a normal pattern for this age group. The usual minimum expiration is 3 seconds for and 6 seconds for adults, but obviously with this high elastic recall, we do see that they are able to breathe out within 1 second of their breath. So it's just be mindful of that, because sometimes you can think that that's poor effort, but it's actually quite common. So all I'd say is look at the patient as a whole. Guidelines are just guidelines, so you know they can't always be applied to and set in stone. So literally, you need to look at you know the lower limits of normals to assess, because as I mentioned earlier, um, the elderly patients have or a natural narrowing as they age, so you know their spirometry can be normal, and I think that's it, Sid. I think I've got quite a